Good morning. It's Tuesday, July 28th. Welcome to The Doctor is In, Ask Dr. Arwady. I'm Sybil Madison, your Deputy Mayor for Education and Human Services, and I'm happy to be here with Dr. Allison Arwady.
Morning.
Your Commissioner for the Chicago Department of Public Health. This is where you can get all of your COVID-19 questions answered, as well as get the latest data on the pandemic here in the city. You can ask your questions below in the chat box. You can also send them via social media on Facebook or Twitter using the hashtag AskDrArwady. We're going to check our physical distance here. We're looking good. So important to keep that physical distance, to do the windmill when you're out and about, and making sure that you are appropriately distanced from others, and to also wear that cloth face covering to keep others safe, as well as keep yourself safe. I think it's so interesting to be out, and I think about you a lot when I'm out and about, and I see other people and kind of do that, like look them in the eye and say thank you for keeping me safe. So Dr. Arwady, why don't we start with the latest data?
Sounds good. So even before we do the data, what I want to just probably make sure folks are hearing, because it's new, sort of hot off the presses this morning, is that we have added 4 more states to the city's emergency travel order that requires 14 days of quarantine when someone returns from one of these states to Chicago or travels from one of these states to Chicago. So today we announced that we would be adding Missouri, North Dakota, Nebraska, and Wisconsin to that list. And we know that Wisconsin is a big deal for folks who live here in Chicago, just recognizing that a lot of people regularly go to Wisconsin. This will go into place as of Friday, and it's the same requirements as the travel order that we've had all along. It does, bring further up the number of states that are required under the travel order. We're putting some detailed information about Wisconsin online, because I'm guessing people will probably have some additional questions there. And I do just want to be clear that we have carved out people who commute from Wisconsin regularly into Chicago for work. They can continue to commute in for work, but they need to limit their activities to work-related activities and to the activities that support their ability to work. And that means, not going and doing social things and other things outside Chicago. And all of this, of course, is just to try to protect the progress. We do set that limit at places that have 15 new cases per day per 100,000 population. And so let's go ahead and look at our data, but I'm going to show you where you can see on our data how we're doing in Chicago compared to that number, because I think it's a question we get a lot. And I'm guessing folks may have quarantine questions, and you can put those in with your other questions into the box. So let's pull up our dashboard here. Just as a reminder, you can always go to chicago.gov/coronavirus, and right up at the top here under latest data, this is where you would go to get the daily dashboard, the daily status report, the hospital capacity, and actually just quickly I'll show you, we've updated our hospital capacity data here so that now you can see not just tables, but you can see real time, getting updated every 24 hours, what's happening with our non-ICU beds, our ICU beds, our ventilators. We're doing very well in terms of all things related to hospitalization, ventilators, in Chicago. You can, for example, get a sense here that dark blue are the number of ventilators that are in use with COVID patients, or even just patients who were awaiting a COVID test on. Then this medium blue are ventilators that are in use in Chicago hospitals, not from COVID, and then the light blue are ventilators not in use. So you can see we have a lot of capacity, and that's the same, across all of our charts here. But we watch this really, really carefully. Obviously, protecting our healthcare system is the top goal of all things, really, when it comes to COVID, beyond, of course, preventing cases and preventing deaths. But back up at the top, of this where we go back under the latest data, and you can get to the data portal. This is where you can download the data. You can get to the mobility report. That's our blue dot data about cell phones and how that's moving. You can see presentations. Every week we update our reopening metrics, which give you more of a sense at a week level how we're doing. But right up at the top here is the daily dashboard, and if you click on that, it will bring you to our daily dashboard. You can also get there directly by going to chai.gov/COVID-dash. And it is mobile friendly, so I look at this thing multiple times a day, a week. It is updated for the public at the same time that it is updated for us. So literally, I see what's happening with our COVID data at the exact same moment that you can see it. We've really tried to be as transparent as we possibly can be, making all of our data available. So I encourage you to explore. So if we look at our daily numbers here, so first up at the top, you can see we're getting close to 60,000 confirmed cases in Chicago. We've tested 431,000 people, and importantly, that's people tested, not number of tests performed. And that is relevant for something we'll talk about in a minute. And we've had more than 2,700 deaths at this point. So you can see that as of today, we're at 240 confirmed cases on average. That is a 7-day rolling average. You can see it's up a little bit from the prior day where we were at 233. We also have people tested here. And again, that's people tested, not just number of tests. Our number of tests done is actually a lot higher than this. We're averaging 6,867 tests per day, but you can see people tested is only around 4,500 of that. And this is because there are a lot of people getting multiple tests. They may be working in a high-risk setting, a long-term care, a healthcare setting, and they're getting tested repeatedly. They may be having symptoms and getting tested. They may be hospitalized and perhaps their first test is negative, but they're following up on it. They may be having a nasal test and a mouth swab test and getting reported. There may be tests coming in reported from their lab, reported from their provider. We work here at the Chicago Department of Public Health to what's called deduplicate those tests, meaning if there is a test that is reported multiple times for a single person, we only count it once. And so that's the difference between people tested and numbers of tests. Our deaths have been at an average of 3 per day, and our positivity rate is at 5.4%, up from 5% or 4.9% where we'd been. And you've probably heard me talk about, we really want to try to keep that positivity under 5% if we can. Now, the reason I talked a little bit about the people tested versus the number of tests done is because at the state level, they actually don't do that deduplication. So they include all the tests that are done. So even if somebody has had multiple tests, within a week, for example, they get counted multiple times. And the way we calculate positivity is the number of positive tests divided by the number of tests done. So this positivity is the number of positive tests divided by the people tested, whereas what the state reports is the total number of tests. And so if you go to the IDPH website, the Illinois Department of Public Health website, and look at Chicago, you'll see that our percent positivity is
going to be lower.
It's going to be lower. It's going to be about 4%. I saw 3.9 last I looked, 4.1, 4.3. But it's often a good point below where we are just because of the different denominator that we're using. The way that we're doing it in Chicago is a little bit more the traditional way to do it for epidemiology. It's more what's being done across the country. It's not that one is right or wrong. And at the state level, they are wanting to very quickly get results out. At the local level, we're doing more of that work to clean the data. But I just want people to understand that there are 2 ways to calculate percent positivity, and we are actually going to add to our dashboard the other way of calculating it, because particularly at the state level, they're using this percent positivity a lot. They've set 8% as a benchmark for where regions, would sort of be on alert or might need to move backwards. And so we want to make sure that calculation is sort of being done appropriately. Yeah. So regardless, we'd like, I would prefer to see that confirmed case rate heading back down towards 200. And I definitely would like to see our positivity rate ideally head back down toward 5%, even with this more conservative way that we're doing it. Also, this graph on the upper right, this shows you our daily case rates across the city. And if you hover over this, if you go to the last day here, citywide is at 8.9. And that 8.9 is the equivalent of the number that we use for quarantine. It's how many cases per 100,000. And so you can see if you look back, over the last month or so, it's ranged anywhere from sort of 7 up to 9. If you look up where we were at the peak, we were up 37, 38. And this is that number that we're requiring people to quarantine if they're coming from states where this is over 15, all right? So you can see here we're at, 8.9, quite a ways from that 15. 400 cases per day here would be the equivalent, basically, of that 15 cutoff, which is why we've said, we don't like being over 200. We're still broadly in control, but we really get concerned if we were to get back up to that 400 level, because that's the level where we've required others to quarantine. So I just wanted to show where you can understand some of where that number is coming from.
And this is interesting because just as we have travel advisories, other states have travel advisories as well.
That's right. And importantly, the whole state of Illinois is right around a 10 in terms of 10 new cases per 100,000. There are about 39 or 40 counties in Illinois that have a higher COVID case per population rate than we do right now. So we have the most cases here in Chicago and in Cook County because we have the biggest population. But where you do this per 100,000, unfortunately, there are a lot of places in Illinois that are having more problems with control right now than we are. And the state did put warnings around 4 counties, not Chicago or Cook, where really they're having some trouble. But all of Illinois getting up to 10 is a trigger because many of the East Coast states, New York, New Jersey, Connecticut, et cetera, have set 10 as their trigger for quarantine. So we'll see whether this gets announced today, but my expectation is that Illinois is going to go on that quarantine list for out east, which means that I now, as a Chicago resident, cannot freely travel to New York, New Jersey, Connecticut, would need to have that quarantine in the same way that some of the others surrounding us are. So it's really a concern. We're not seeing good control broadly, even while Chicago has remained broadly in control. Our numbers are creeping up there, and all around us we're seeing real problems, and I'm concerned about where things are going to move. Maybe we'll just look quickly for the sake of time. I'll remind you up here at the top is where you can click weekly. And you can look and see the most recent week. And weekly is how I really encourage you to look at what our progress is looking like overall, better than the day-to-day fluctuation. So you can see that, last week, the week ending July 18, we were at just over 1,500 cases, down 11%. We'd had some increase in people tested. We'd had some nice decrease in deaths. And the positivity rate was actually at 4.5%, down from 5.4 the prior week. So I encourage sort of looking at these weekly numbers, and even on the graphs where you want to look and see where do we need to pay attention to positivity, et cetera, look at the weekly view.
Yeah, just quickly.
Yeah.
Because on the dashboard, what's nice is that there's color coding, right?
Yes.
And so when we look at the daily, we're seeing a lot of red. When we look at the weekly, we're seeing a lot of green.
Yeah.
What should we make of that?
Yeah, I think just that the daily numbers fluctuate a lot more, right? I mean, even though we smooth them out a little bit with averages, we know that we will see things sort of move. And so it's important. We don't want to wait a whole week to sort of see where we're going. But it's better to kind of understand more at a weekly level, how are we doing with our outbreak broadly. And we do, where we're making decisions about pulling back on things, there's not just one number that's the automatic number there. Yeah. It's certainly the case number, it's the percent positivity, but it's also how fast are these numbers changing. And we never make a decision based on one day of data. We really look at it over a week or 2 weeks or 3 weeks, depending how fast we're seeing that change.
Got it.
All right.
Okay. Oh, are we ready for questions?
I think so.
All right. And we have quite a few. At Court Teresa from Twitter, Dr. Arwady, what is the difference between positivity rate and infection rate greater than 15 new COVID-19 cases per 100,000? We just talked about this.
Okay.
Having watched your briefings over the last 4 months, everything was about the positivity rate. So this is kind of touching on a couple of things here, I think, that we just talked about.
Yeah, sure. So let me help clarify that. So the positivity rate We certainly like and care about the positivity rate because it is the number that helps us know especially whether we're testing enough, right? Because again, it's our number of positive tests divided by either the number of people that are tested or the number of tests that are done. And there are certainly places that are in very poor control from a percent positivity rate. So, here we're at around a 5% positivity rate, broadly in control. There are many places around the country, Miami, Las Vegas, et cetera, where they're 4 times it, 20% positivity rates. Like, just in no way are you in control where you have a high positivity rate. But also, if we kind of take this down and sort of think about what it looks like in practice, if you're not doing enough testing, your positivity rate can really fluctuate wildly. So, if you only test 5 people, one of them is positive, you'd have a 20% positivity. 2 of them are positive, you'd have a 40% positivity. So some of the percent positivity can really be affected, first of all, by things like deduplication, but also by how much testing is happening. And so we never look just at that. The 15 case per 100,000, and I know that can be a little confusing for people. It's why we've turned the numbers into these 200 number, 400 round numbers. That has the percent, the number of cases per 100,000 already baked into it. When we are adding in Chicago 200 cases per day, that means we are at a high incidence. You've heard us talk about this, a high risk. And that is based on the number of cases per 100,000, if you kind of get into what that number looks like. Where we're adding 400 cases per day, that's adding the equivalent of 15 cases per 100,000. But I know it can be confusing for people. So part of the reason, I just went over on that dashboard is to show you kind of how they fit together. The percent positivity to me is a great crude number that lets you know broadly are you in control, but it's also broadly about how much testing you're doing. When I talk to my counterparts around the country, what we talk about are how many cases are we seeing per 100,000. So, I was on a call yesterday and I said, we've had a rate around 8 or 9 per 100,000 per day. That helps us all sort of compare numbers in the same way. That 8 or 9 per 100,000 is the same as having 240 new cases per day. They're just flip-flopped whether you're talking the population in it or not. And that's one way of comparing. If I were going to choose one number, it would be that 240 number, because that is the number of how much COVID how many cases we have here. And when that number is higher, it means there is a higher chance that in a group of any given size in Chicago, you are going to have someone with COVID in it. And so as that number, that's the number of the epi curve. That's the number that goes up and down. That's the number that lets us know how much COVID is here right now and therefore what the risk factors are. So that's my favorite, but we look at that in conjunction with percent positivity and then a lot of other factors as well.
Yeah, okay. Hopefully, Court Teresa, that was helpful. Apron Johanna from Facebook. I'm a little confused on this travel order.
Okay.
So we only have to quarantine if we only stayed 24 hours in one of the high incidence states. What if we only go to visit family? My second question is, will Chicago go back to phase 3 or back to a stay-at-home order because of the increases in cases and positivity rates? So the first question is about the travel order, and if we only stayed 24 hours in one of these states, do we have to follow the quarantine?
Yeah, so if you look at and you can go to chicago.gov/coronavirus, right up at the top is a lot of information about the travel order, a lot of frequently asked questions, a lot of details. We exclude people who are traveling through a state. So we get this question a lot. Say someone is traveling from one area to another and they're passing through a state, does that count? And you are allowed to pass through a state without it sort of counting against you. It's not really meant to be like I'm going for a day trip, I'm going to visit family, because then you actually are going to interact with folks in Wisconsin as opposed to just transiting through. In the same way, people can transit through O'Hare O'Hare or Midway or Amtrak or the bus terminal if they need to, right? Without sort of getting caught in the quarantine. They can move on to other parts outside Illinois or go to Michigan or wherever they're heading from there.
Your layover, your gasoline
Your layover,
stop,
you're allowed to sort of do those things without getting caught in the quarantine. But it's not meant to be, if you're actually traveling to interact, you would have required quarantine as a result of that.
So just to put a
Yes.
finer point on it, because I think there might be people who think, oh, well, I just went and I was only with my family and we stayed in the house and we didn't.
Yeah.
Doesn't matter.
It doesn't matter. And, and I know this is hard, and I know, I've gotten a lot of questions about, why can't you just put it on one part of the state? And, can we make an exception for people who have a second home? And can we do this? And can we do that? And, the bottom line is that this is just about us trying to have our outbreak in as good a control as we possibly can. Because if we can't get our outbreak in good control in the summer, looking ahead to the winter where we don't have a lot of these outdoor opportunities, right? Where we are the biggest open city right now. There's no other city that has an outbreak in reasonably good control, which we still are, and we'll answer the second part of that question in a minute, that has the amount of things open that we do. New York is doing better in terms of their number of cases and their percent positivity right now, but they also don't have restaurants open, don't have gyms, lots and lots of things that we have open here, they don't have open. There are other places that opened sooner than we did and have had to take much more significant steps backwards, closed a lot of things. So we are really sort of at this point where, fairly unique in the country for a large city, we are relatively open and relatively in control. Can we hold that is the question.
Right.
And to the point of sort of, are we at a point where we would need to roll back? So right now, no. There again, to the point of there being a lot of different metrics and a lot of different numbers and a lot of different ways of measuring. I will just note that, I think it's likely at some point that we will probably have some federal standards and guidance perhaps, so that people are counting things and reporting things in the same way, but that has not happened as much as it perhaps has in the past. And so this is part of why we are seeing slightly different ways of, calculating and deduplicating and setting cutoffs for quarantine and all of that. And I do know that that can be difficult for people. But what we're looking at here, first of all, would be at the state. Okay, so we are, Chicago as one of the regions of the state, of course, is held to what the state has set up for potential rollbacks or where you might need to do that. And that, for example, is where that 8% positivity comes from. And that 8% positivity is based on the state's way of calculating positivity. So where we'd be at about a 4%, give or take right now. So that marks sort of a point where you, depending how the other metrics look, what's happening with your hospitalizations and your ICUs, what's happening with your number of cases, there are some things that the state has set. And then for us here in Chicago, we also, we have the ability to be stricter than the state if we would like to, not less strict. The real line in the sand that we have set here for where we would be thinking much more seriously about the need to roll things back, it's not like there's an automatic one day doesn't pop you up or down, but if we were consistently seeing our case rates back over that 400 cases per day, that to me and to us says broadly we're not in great control here. And depending if and when that happens, hopefully we've learned more at that point about which actions have the biggest impact. So for example, I follow very closely research that's coming out around the world. There was a big study that looked at things that cities have put in place and countries have put in place and found that shutting down public transit had no impact on COVID spread, right? So as we learn more about that, we also use that to make decisions around what we may or may not roll back. But for us here, I would be concerned and we would be thinking pretty seriously about putting some more significant rollbacks in place if we were at that over 400 mark. And it could happen. It absolutely could happen. It could happen soon. My hope is it won't, of course. And if people keep doing the things that we know work, and people in Chicago are broadly doing a better job of doing things like wearing masks, keeping distance than even many other parts of Illinois. Wisconsin still does not have a mask order in place, for goodness sakes, right? And so I want us to keep doing the things that we know work, and we will keep things open as much as we're able to, as long as the outbreak supports it.
Yeah, it's reminding me of the
dial.
The dial,
Yep.
And we've had to dial.
That's right. We dialed back a little bit even just last week. And that, again, we were seeing this very much driven by younger Chicagoans. We looked at our data. Where are we seeing, that risk? Where are some small places that we can hopefully make some small pullbacks without needing to do those major pullbacks, like going back to level 3 or, going back into shelter at place. And we'll keep doing that. We're really looking at the data every single day, and making decisions. I don't make these sorts of decisions. We don't make these sorts of decisions lightly. We know that they have impacts on businesses and people's lives and social activity and travel plans. But at the end of the day, we're trying not to confuse people and make too many changes all the time. We make changes when the data suggests that we need to, and we have been trying to signal in advance where we have concern.
Yeah, I like how you said we're protecting our progress.
Yeah, that's what we're trying to do.
Okay, Zoletta Strega from Facebook. Can food preservation methods also preserve the virus, such as vacuum sealing, canning, and jarring, since the virus can withstand even boiling temperatures up to almost 15 minutes, which exceeds even pasteurization? So this seems like one of those...
Interesting. There's a number of things in there. So first of all, let's just remind people that we don't see COVID spreading through food. Okay, first and foremost, or through water, drinking water,
Yes.
drinking, eating. When you eat something, even if it had some COVID on it, by and large, it's going down to your stomach, and the acids in your stomach are sort of taken care of. We've not seen...
It's not going into your respiratory system.
It's not going into your respiratory system. Now, of course, your mouth, right, is the entry point for both your respiratory system and your GI system. But by and large, food is not the major concern. It's more you want to be washing your hands a lot before and after and doing all those things. The question of canning is interesting because this gets at, there's something in that question that's not actually accurate, and I do want to address it. So it sounds like the questioner is canning food, which is great. I want to make sure you're following all of the safe procedures around canning food, and that has to do with getting things up to the right temperature. I don't worry about COVID in canning. I worry about things like botulism if people are not practicing appropriate procedures. But assuming you're an experienced canner, COVID is killed by boiling water or anything else. So if you're boiling for 15 minutes, there's not COVID living there. Okay. There was, and maybe again, I always, when people have questions like this, I usually, it's coming from somewhere, right? It's coming from something that someone's reading and interpreting, and I really appreciate it when people put questions like this forward. There was something that came out a couple of weeks ago that raised a little bit of attention, where they basically said, are the typical lab procedures that are done to sort of clean test tubes and things in the lab where we're studying COVID, are those adequate? Because what they found, typically, even in like a pretty high level laboratory with the safety things in place for, Ebola and all these other diseases, typically 60 degrees Celsius, 100 degrees Celsius is boiling, 60 degrees Celsius is generally considered good enough. And there was some amount of virus still living in this laboratory setting, not enough to necessarily infect people, but still some of it was there. And so there was some tightening of safety restrictions in those laboratory settings to help protect the people who are doing laboratory testing for COVID, to increase the temperature, to increase the amount of time. But that was
a very different situation.
A different situation, and not boiling, right? Not that was 60 degrees Celsius as opposed to 100 degrees Celsius, which is the boiling. So I appreciate the question, but you can do all of the safe things around canning. And again, the food preparation is not my biggest concern at all when it comes to COVID. It's being in close contact with living, breathing people. And that is by far the biggest risk factor.
Okay. Kristen Korkowski from Facebook. If we have a vaccine, will masks no longer be needed?
Oh, good question. So masks are going to be with us for some time, even after a vaccine is available, and all things have been looking promising at this point for a vaccine becoming available. We've got some vaccines now that are just getting into those phase 3 trials, which are the really big trials where we give the vaccine and a placebo, like a dummy vaccine, to tens of thousands of people and test to make sure that it's effective, that it doesn't have side effects, like all of those appropriate safety and efficacy things are in place.
And you've mentioned before that the government is investing in production.
That's right.
So that, we're one of these vaccines to make it through.
Exactly.
We would have
exactly.
Vaccine ready.
Right. We're producing now while we're waiting for these test results. If the trial is not successful in the end, then you would have to throw away a lot of unused vaccine. But if it's successful, you've shaved off months or even years off the typical process. It's a safe way to be able to speed this up. But to the question of whether we will need masks. So even after a vaccine is available, my best guess is still early 2021, I think. It's possible we'll start to see, if all goes really well, maybe by late 2020, we'll start to see some of these trial results, hopefully be positive and available. But I think it'll be early 2021. If I had to guess, first quarter. That's actually been my guess for 6 months, and it's still my guess. Yeah.
The irony being that we have all these states with high incidence, which kind of helps with the trial.
It does help with the trial, ironically. That's right. Like trials, the phase 3 trials, you have to, the whole idea is you give vaccine at the highest level, like sort of generalizing a little bit, you give real vaccine to half the people and dummy vaccine to the other half of the people. The person does not know whether they received the real or the dummy vaccine. The person injecting does not know, the researcher. It's all it's what's called double blind. It's behind the scenes. And then you follow these tens of thousands of people forward and you count the cases of COVID at the most basic level. And so, unfortunately, if there is a lot of COVID and a lot of spread, it is faster for more cases of COVID to come through. And then once you've had enough cases of COVID detected in your tens of thousands of people, you unblind the study and you basically open it and you say, did we have a lot more cases of COVID in the people who did not have the vaccine than the people who did? And you have to show a certain amount of efficacy to say, yeah, that vaccine really helped. So unfortunately, where the outbreak is not in good control, it speeds up the trial a little bit. Again, not in a way that compromises safety, not in a way that gets around all of our very, very good vaccine safety and trials, but just because of the amount of COVID. So, let's say early 2021, vaccine is available. There is a long way between vaccine being available and vaccine actually being able to be administered to, essentially be made available to everybody in Chicago. At the beginning, this is going to be prioritized. It'll be available probably for healthcare workers, depending on how the trials play out. There will be some prioritization likely of, older people who we certainly know have been at the highest risk. It probably won't be available for kids right at the beginning. There will be additional trials for women who are pregnant that need to happen. It's going to be a process, even after a vaccine is available. Even the logistics of this, I think it's looking like good chance we're going to need a couple of doses of this, and that doubles the number of, glass vials and syringes and procedures, and it's going to be an enormous lift in Chicago and around the country to make this vaccine available. So that's going to be at least a year, and during that whole time period, we're going to continue to need to protect each other. Yeah. So masks are with us, and that's why, I said this morning to somebody that we're having a lot of conversation around things like school reopening, and I totally understand this is a difficult conversation. If COVID were going to be over in a month or two, this would be an easy decision, right? Of course, we would all hunker down and wait 2 months, but it's not. This is going to be couple of years, realistically. At the health department, we're planning 2 to 3 years where we think about sort of the COVID response. And throughout that whole time, yes, we'll be working toward this, but the vaccines, it's not going to be 100% protective, most likely. And even as more folks are getting vaccinated, there probably will be some people who decide not to get vaccinated. There probably will be some people that will be waiting on trials for pregnant women, for example, right? You'll want to be extra sure that that vaccine is safe before it's available. And so for all of these reasons, we're going to need to continue to do the things that protect each other while we continue in in our new normal. So
Right.
I wish I could say that COVID were, going to be over shortly, but it's not. And us doing everything we can to support folks who are at higher risk, not have an outbreak that's out of control, lets us be more open and have more possibility for the things that everybody enjoys here in Chicago.
Yeah. So these new behaviors are going to have to
Yeah.
become our new norm
I think
in terms
so.
of what we do.
I think so. And that, we see that around the world. We've been seeing cases, rising and falling, and nobody thinks COVID is over anywhere. And even once a vaccine is available, it's not like COVID's going to instantly be over then either.
Yeah. Good for us to have that perspective. So thank you, Kristen, for the question. Jean Brooks from Facebook. Will the usual flu vaccine be available at the usual time?
So flu vaccine is probably going to be available even a little sooner than it typically is. If folks don't follow flu vaccine, we actually make a new flu vaccine every single year. And that's because influenza mutates a lot, especially COVID. One of the good things is we've not seen a lot of mutation in a way that would make it difficult to produce, a vaccine. But influenza, there's lots of strains of influenza. Different strains will sort of rise and fall, and we'll see different things in a given year. And so what we actually do is we look and see what's happening with flu in the southern hemisphere, where the seasons are opposite. Flu season everywhere is in colder weather. And then we create a new flu vaccine every single year based on the strains that are circulating in the southern hemisphere. And then they do the same thing for us. They look and see what's circulating in the northern. And so that's why you have to get a flu vaccine every year, because the one you got the prior year, is not necessarily protective against what was circulating the most. And the flu vaccine is not 100% protective. And that is maybe where we end up with COVID. But what it's very important for is it's really, it helps a lot. It brings it down, it brings the risk down a lot. And it really helps protect against severe flu, the kind that that puts people in the hospital, or that unfortunately causes people to die. So we really are going to need people getting flu vaccine, because the last thing we want this winter is our flu season, which we already know puts a strain on our hospitals, a strain on our healthcare system, with any amount of COVID on top of that. So the flu vaccine is likely going to start being available as soon as late next month. We usually see it more kind of in the September-October frame, but it looks like we'll be getting some doses already in late August. And I would really encourage you to be reaching out to your doctor, your pharmacy, wherever you typically get your vaccines, and be getting your vaccines in now. It's a good time when our outbreak is in good control to be doing that. We are also following, this wasn't the question, but I think it's interesting, to see what is the flu season looking like in the southern hemisphere, right?
Ask.
At the time
we're doing other things.
We're doing all of these other things. And so far, it's been quite mild. We're seeing some flu, but much less than you normally would. We still have a long way to go there in terms of what the season will look like overall. But the hope is that these things that we're doing to protect ourselves, as long as we keep doing them during flu season, will also help protect against flu. And that's so important, because the mix of sort of flu vaccine with these behaviors is just going to be so important, because where I worry about the healthcare system is these two on top of each other.
Yeah. Okay, I think we have time for just one last question from Sarah Good Mosley. Question coming in from Facebook. A person in my building won't wear a mask because he already had COVID-19 and doesn't think he needs to wear one anymore. Is this true?
Yeah. So the absolute strongest message I can give on this is that we are still learning about COVID-19, about what our immune system does after exposure to COVID-19, and the very strong recommendation of the Chicago Department of Public Health, the Illinois Department of Public Health, the CDC, the WHO, everybody, is not to assume that just because you've had COVID, you don't need to take the protective actions that everybody else does. We've been learning, for example, that people develop antibodies after exposure to COVID. That's this antibody test that we've been talking about. But those antibodies don't necessarily last. And some of this is a little bit around how bad was my COVID infection. People who have a more robust immune response because they get more seriously ill with COVID probably have a stronger immune response. Now, I don't want you to think because the antibodies are gone, there isn't a possibility still for an immune response, because that's not what I'm saying. There are a lot of different kinds of antibodies, and even besides antibodies, there's another whole kind of immunity that comes from your T cells that probably also would have some level of protection. But the bottom line is we just don't know yet. And the last thing that I want someone doing is thinking, oh, because I had COVID, I don't have any risk. I can't, I don't need to worry about others. I don't need to wear a mask. You need to wear a mask. You need to do the things that we know work. And as we learn more, we'll have some of those questions answered. In my best, hopefully we'll find out that it's true that someone who has had COVID, is not at any additional risk, but we just can't say that right now based on what we know. And particularly at a time where our city overall is at some real risk of COVID spread, I don't want people thinking that they don't need to do their part at the same time. We've only had this virus like in the world, 6 months or something. So in terms of knowing how long immunity may last, even if it's there, that's still very much an open question. And I just ask everybody to do the simple things that we know work. Where we see people, you don't want to be in a conversation with someone saying, I don't need to wear a mask because I had COVID. Like, that is not based in science in terms of any of the recommendations. And it also just sets up, I think, unnecessary conflict and potential for confusion. Please just wear the mask. Keep your distance, do the things that work. It's a relatively small price to pay for really it's one of the best things we can do to help protect our city and everybody who lives in it.
Yeah, it reminds me of the campaign that just got started by our local sports teams.
Yeah.
We're all one home team.
We are all one home team, right? Like during the when we were under stay at home, there was a campaign, We Are Not Playing, which they really helped with. And then now this, we are all one home team. It's like, the White Sox versus the Cubs. I mean, normally there's a lot of these rivals, but when it comes to something as basic as wearing a mask, as basic as doing the thing that we can do to protect our neighbors and protect Chicago, we are all one home team. And I'd love people, regardless of whatever history they've had with COVID, to keep doing their part.
Yeah. All right. How about some good news, Doctor?
All right. Some good news. First of all is that we've got another trial open for people who want to be part of the vaccine studies. So just like I was talking about, there are now a second trial opening in Chicago for people who would like to be part of a vaccine study. Again, this would be, you'll get more details about it, but you have basically a 50-50 chance of getting either the vaccine or a dummy vaccine. And you're followed and your blood is checked to see what your immune response is, et cetera. And we had already announced the first one available was at the University of Illinois at Chicago. So you can email those folks as a reminder at Project Wish DOM for Department of Medicine. That's Project Wish DOM at uic.edu. But also now Northwestern is enrolling another, and this is a different vaccine, right? There's multiple vaccines that are under study. So Northwestern is enrolling at NU Vaccine Study. That's NU Vaccine Study at northwestern.edu. They are both, to my knowledge, enrolling people now, and you'd get a lot more information, of course, about the details. But you can email them or you can look online. And we're especially interested in getting people from a range of backgrounds in Chicago. We definitely want folks from communities that have been hardest hit. And that would be Latinx Chicagoans, that would be African American Chicagoans, that would be older Chicagoans, really looking to have our vaccine studies look like Chicago looks. Because when we can do the studies in a way that reflect what our city looks like, we then have all of the safety and efficacy data that we need. We will not have a vaccine available in this country until we know that it is available and safe broadly, including for people of different ages, including for people of different race and ethnicities. And so please, if you're interested, reach out and see if you can be part of that vaccine study.
All right.
One other maybe just good point would be that the mayor yesterday announced an additional $33 million in housing assistance for Chicagoans. It's a big deal. Already there had been some funding available, but we know what a strain this has been for so many families here in Chicago. And so In addition to the eviction counseling and some of the other work, there's another round of funding available. You can go to chai.gov/housing help. And this is in conjunction with the Department of Housing, the Department of Family and Support Services, more to learn, but chai.gov/housing help if you've been having trouble paying your bills related to housing as a result of COVID. So that was really an important investment where we think about equity and our long-term need to think not just about the direct, but the indirect effects of COVID.
Yep. I will just add just a reminder to those of you who are CPS families. There's a lot of work being done this week for everybody to understand their preliminary reopening framework. And so there are town halls happening, I think, every day this week, some in Spanish. And there's also a survey that's been launched. You can go to cps.edu to get information about all of that and to add your voice to the mix in terms of things that you want to share with CPS about their plans.
Great.
All right, so back on Thursday.
Back on Thursday.
At 11.
At 11, we're going to have one of the contact tracers who works at the Chicago Department of Public Health come on and talk about the details of case investigation and contact tracing. This is someone who spends his day calling people with COVID and contacts and is very good at his work, and really, we get a lot of questions about this, and so wanted to share some of that with you. So you can tune back in if you've got questions around contact tracing or anything else. We'll be back at the regular time on Thursday.
All right, sounds good. So we're all one home team.
Yep.
Be safe.
Be safe, Chicago.